Hi everyone.
Hello.
Hi.
Okay, shall we make a start?
Yeah, we're just after 1 o'clock, so we can just watch the waiting room, can't we?
Yeah, I can do that. Well, hi everybody. Thanks for joining us. For those of you that don't know me, my name's Joanne Wright, and I work with Louise Kirby in the Support and Information team at the Bone Cancer Research Trust. Just a few bits of housekeeping before we start today. If you just keep yourself muted whilst Dr Fitzgerald's talking, just cuts down on background noise. And also to let you know that we'll be recording today's session so that we can put it up on our YouTube channel. So if you don't want your image to be seen, just keep your camera turned off. There will be a chance to ask Dr Fitzgerald some questions at the end of the session. But if we can just keep them to like a general nature really, rather than specific to individual circumstances. If you do have a question that you would like answered, if you email Louise and I after the webinar, we'll try our best to sort it for you. I'll just pass you over now to Louise, who will introduce today's speaker.
Thanks, Jo. So today actually marks our 8th support and information webinar. So the plan for this week was going to be a little bit different. So we were very fortunate to be joined by 2 speakers for our discussion on cancer and fertility. Unfortunately, Becky has not yet come into the Zoom call, so we'll keep an eye on the waiting room. So we're going to hear first from Dr Cheryl Fitzgerald, who is a consultant gynaecologist at the Department of Reproductive Medicine at St Mary's Hospital in Manchester. So Dr Fitzgerald will start off by giving us an overview of her work, the fertility services currently offered within the NHS and the realities of fertility treatment. And we'll watch the waiting room and see whether we're joined by Becky, and then we can introduce Becky separately. So I'll firstly hand over to you, Cheryl, and thank you so much.
No, well, thank you for asking me. As you know, this is something that's an area that's very, very close to my heart. So we had a very long history of an established fertility preservation service for men in Manchester, going back 30, 40 years. But we had nothing for women. So in 2008, I set this service up in Manchester because I thought it was really very, very important. And now we have certainly one of, if not the biggest NHS services in the country, but certainly one of the biggest. So we have a dedicated clinic each week, and we have a dedicated nurse who works with our oncology patients. Although sometimes we see patients who have other conditions where the treatments have similar effects on fertility to oncology treatments, so we do see them as well. So I think the first thing is really, what is fertility preservation? Well, I don't think fertility preservation really exists because you can't preserve fertility. I think it's more about seeing patients to discuss the potential impact of any treatment they're going to have, what that impact is on their fertility. And then to see them afterwards to try to maximise their chances of a pregnancy. And I think pretty much anybody can become a parent, but we can't guarantee to anybody that they can have their own genetic child, which they can carry in their uterus themselves. You know, there are lots of ways of parenting: donation, adoption, surrogacy, but I think most people set out from the point of wanting their own genetic child, and they want to carry that child themselves. So I think our work is to work with the oncologists at every step of the way to reduce impact on fertility, and then to maximise the chances of those patients going forward. So we know that chemotherapy, which obviously a lot of oncology patients have, reduces the number of eggs in the ovaries, and it also reduces the ability of the testes to produce sperm. We know that localised radiotherapy, so radiotherapy to the pelvis, has a similar effect, but it tends to be much more toxic really. But also with radiotherapy within the pelvic area, that can also affect the uterus and the ability of the uterus to carry a pregnancy. So the oncology treatments can have profoundly damaging effects on fertility, not always. And it depends obviously very much on the individual patient and the treatment that they have. So our role, I think, is to work very closely with the oncologist to raise awareness of fertility so that they refer patients in. We also see patients urgently before they start oncology treatment to see if we can actually preserve eggs or store eggs or store sperm. We also see patients several months after they've completed their oncology treatment and do a sort of a fertility assessment, if you like. You can't say somebody's going to become pregnant, but you can start to build a picture of potential problems they may have. And then we see patients when they try to get pregnant and if they're not getting pregnant. So I think our role is really a sort of quite a long-term role along the oncology pathway and seeing patients at several stages. And obviously what we do at any of those stages will depend on the individual patient. I think the thing people tend to think of fertility preservation is just about banking eggs and sperm. And as I say, I think it's much bigger than that. But if we look at storing eggs and storing sperm is extremely easy, it's extremely quick, it's very cheap, and it's actually remarkably successful. And unfortunately, egg freezing isn't. If somebody wants to bank a sample of sperm, they a couple of blood tests, they come along to the unit, they produce a sperm sample, and then we bank that sperm in several straws of sperm. And I think the very important thing is that single sperm production can then go on to be enough sperm for several cycles of fertility treatment in the future. So if you look at an IVF cycle, there's about a 1 in 3 chance, if the woman's young, there's about a 1 in 3 chance that would be successful. And a single sperm sample could produce enough sperm for 20 IVF cycles. If you bank eggs, it's much more difficult because it's much more invasive. It takes longer, it takes about 2.5 weeks. And that whole treatment cycle will give 1 cycle of IVF. So whereas a sperm banking sample can go on to have a very good chance of success from a single cycle of eggs storage, you're looking at possibly about a 1 in 3 or a 1 in 4 chance of a pregnancy. And obviously that will depend on the age of the woman who comes through. So it's not great, unfortunately, for women. I think, there is this biological difference between men and women, and it means it's much more difficult and it's not as successful for women. But it doesn't mean it never works. It can work. And I think it's absolutely crucial that women are referred into us before to discuss whether they wish to bank eggs. And then, as I say, to see them then afterwards, I think is equally, if not more important. Success rates are improving. When we started this in Manchester, you couldn't bank eggs because the success rate from banking eggs was absolutely abysmal. We didn't have the techniques to bank eggs, whereas actually that's now much more successful. And it is, it's still only 1 in 3 or 1 in 4, but that's still a reasonable chance. And who knows what the future might bring. I mean, I don't want to sort of, give people unrealistic hope. But actually, we're seeing massive development with stem cell therapy, and certainly in a research setting now, people are starting to produce sperm from stem cells. Eggs are much more difficult. They're very difficult cells. But who knows what the next 10 years will bring. So I think it's just important for us to kind of continue to raise awareness. And I think, patients need to know that there are lots of complications of oncology treatment. And I know a lot of the patients I see feel that the information they're given about the potential impact that this will have on their fertility is actually almost at times worse than the cancer diagnosis. So I think it is about raising awareness and keeping that dialogue going with oncologists. And certainly here in Manchester over the last 10 or 12 years, I think that's been really successful, and we work very, very closely with the oncologists now. So I think putting on sessions like this is so important, really, as a way of raising awareness, to the wider audience, and particularly to oncology patients.
Thank you, Cheryl. Thank you so much. Such an informative overview of the services currently offered fertility preservation in the UK. So at this point, we're going to pass over to Becky, who is going to discuss her experiences of fertility preservation throughout her experience of osteosarcoma with Joe. But unfortunately, it doesn't look like Becky has joined the Zoom call. So I think what we'll propose instead is just a bit of a general Q&A. If anybody wanted to ask something, you can either unmute yourself or pop it in the chat function box. If there's no questions at the moment, Joe and I had a couple that we could kick off with.
I think, Lou, actually, Sally Smith would like to ask.
Okay, sorry, Fab, thank you.
The question. Are you okay asking the question, Sally?
Yes, I am. It was just really how soon after finishing chemotherapy can fertility be assessed?
So eggs take, I think people tend to think because a menstrual cycle is 4 weeks, they tend to think eggs take 2 weeks to grow, whereas actually they take about 9 months. They take a very long time. So these immature eggs are laid down in the ovary, and then from that very immature stage to being released takes about 9 months. So I wouldn't suggest assessing somebody until 9 months after the end of their chemotherapy.
Right.
Obviously patients want to know, but I think if you come in at 6 months and you get a result that's not very good, you end up repeating it. So I think 9 months is perfect. And at 9 months, that's where it's going to be, really. I think you can be quite confident of that.
Okay. Do you want to ask your question, Lou?
Yeah, so mine was just really, well, you've answered it a little bit, but how have fertility services changed over time, and what you think really, I think you've sort of touched upon it with awareness, but what you think is needed to be done in order to improve every patient's access to ensure that the correct discussions are had at the right time?
So I think increasing awareness isn't a simple thing. You can't just put a poster up and say, right, everybody knows. And I think I spent the first 3 or 4 years after I set this service up. We've got a very big oncology hospital in Manchester, and I must have spent more time, I think, almost there than I did in the IVF unit, saying to people, refer in, and now they do. I think it's, I think, it varies across the country. It also varies across specialties. So when we set this up, we set it up with the breast cancer service, because obviously breast cancer services have very, very, in the majority, it's women who get breast cancer. Some men do, but it's very rare. So it's a predominantly female orientated service, and it also is a condition that does affect quite a lot of young women. So I think that was something that was almost on the radar of breast cancer specialists. So they sent patients in, but then it did take, I think, a lot of time to talk to other services, because I think there are lots of cancers as well that don't happen very much in young people. So that's something that people don't realise. And also, I think, understandably, oncologists are absolutely focused on getting people better. That is their aim. And I think fertility is something that just tends to get forgotten. So I think it's just really important for patients to mention it. And I think another problem we had at the start was that actually we were getting patients who were being referred in from their oncologist, certainly in the breast setting, not from their surgeon. So they were coming in when they were due to start their chemo, 4 days later. Whereas, to be referred in very, very early in the pathway is really important, because then that gives us time to freeze eggs. Sometimes we even get time to go through 2 cycles of treatment and bank twice, which obviously will increase the chance of pregnancy in the future. So I think things have got better with, education, and certainly in the world of fertility, there's, fertility preservation is now a big deal, but we're almost the wrong people to spread that message to. It's the world of oncology, and I think certainly over the time that I've been doing that, I think working with oncology nurses has been really effective, because they spend more time with patients often, and they're often the people who have actually spread this. But I think it's taken us a long time. But I think in Manchester now, I think we don't get women. It was almost fixed in the cancer pathway for men, and it was almost something that was always ticked off. Have they been referred in for sperm banking? Just didn't happen in women. But I think now, there aren't many people who are missed, if you like. I think people do have that discussion and come in.
Okay. That's really
I think
good.
what you're saying as well is that it's important, it's not just for the oncologists to be aware of this, it's for the patients as well, so they can be raising it with their treatment team right at the beginning, at the very start of the process, before time runs out for them effectively.
Absolutely. And sometimes we see patients who there is a very high chance that this is an oncological diagnosis, which is going to need chemo or whatever. And sometimes we see those patients and have those preliminary discussions. In fact, sometimes not often, but occasionally that histology will come back, and it isn't that. But I think because they're in the system, if then they do have to have treatment, it just limits the time, because what you don't want to do really is delay chemo and delay oncology treatment. And that's why we have to work very closely with the oncologist, because the most important thing is that people get better. Absolutely. Fertility is very important, but it's not as important as getting better. So we do, that's why I think, you need to maximise the time, but certainly we would always work very closely with the oncologist, and very occasionally there's a situation where it's just too risky to do fertility preservation and we can't.
Okay. Well, we've actually been joined by Becky. Hi, Becky.
Hi, Becky.
Nice to see you.
I think you're on mute.
You're on mute at the moment.
Sorry, I was on my computer. It's slightly different. Sorry about that.
Yeah, no, I'm so glad you could join us. So I think perhaps if we there are a couple more questions that have come through. So I think if we perhaps just park them till we get to the end of Becky's part of the webinar, and we'll just have a chat to you, Becky, if that's okay.
Yeah.
And this part of the webinar, I think Louise explained, is going to be like a form of, sort of questions and answers. So I'm going to ask Becky a few questions, just as prompts really for her to talk about her diagnosis and her experiences of cancer preservation. So Becky, if you could just tell us a little bit about your diagnosis and treatment for primary bone cancer.
So mine was slightly different. I had a benign tumour first in my sacrum, lower spine, and so that was at 18. And I thought it would only stay benign, so it came back a couple of times. So I thought, that's it. That's the worst I can get, is paralysed, but it's not going to kill me, I hope, anyway. And so it came back a couple of times. It made my walking very deformed because it was on the nerves. That's how I knew it was coming back, because you literally would see me and I could barely walk. That's how I first knew, because when you don't know what you have. So if you can imagine, I had a younger brother and I said to him, I can't walk. I literally can't walk. Every little step was really hard, and he literally had to carry me. He didn't know what was going on. He thought I was maybe joking, and then he realised, no, she's not. And then my mum saw it and brought me to the hospital, and unfortunately I got misdiagnosed. And then fast forward, so I had specialist treatment in the same hospital for sarcomas, which I didn't know I was going to get a sarcoma later on, which is really weird. And so my specialist is a sarcoma specialist, but my sad story was, unfortunately, when he was away, when I had red alerts saying there's something wrong, they kind of dismissed them. So then that made me wait longer for treatment, but also I was waiting a long time anyway. So that's why I kind of had a bee in my bonnet, was I actually had the time, but no one gave me the choice. And also they were talking for months in my case, and I thought that could have been a case where, while I was waiting, because they were so worried because they had misdiagnosed me, they really thought I was going to die. So I don't think they even thought about fertility, which, to be fair, if I'm waiting anyway, what difference is having it? If I didn't have time, I could understand. I'm all for, if it's detrimental to your health, obviously, you've got to do what's right for you. But if there's time, then there should be a case by case basis where that should be a choice that's valued. It just makes me feel like, when people, it's great, you're happy, they're happy you survive, but they don't happy about you as a person and what you want, which doesn't make sense. So if you're happy, if you want me to survive, you should want me to have a good quality of life as well. That makes sense.
Yeah, absolutely. So you sort of answered the next question, really. We were going to ask you, what was your experience around fertility preservation when receiving the treatment for it? It was osteosarcoma, wasn't it, that you were diagnosed?
So yeah, osteosarcoma at 21.
Yeah, and what was your experience? Was it ever raised? Was it ever mentioned, or was it just?
Well, my problem was in 2008 in London, where I had my treatment. I was 21, but now it goes up to 25 for young adults. So I was on an adult ward asking for fertility and things that younger people, most of them may have gone through the menopause who I were around. So, and also, even though they do good things in general, the charities that were connected to the hospital, because I was in an adult ward, you kind of got missed out. So I think that's where the trauma came in, because if I had someone who knew about young adult issues, and especially fertility for some people, I feel like they would have sent me in the right direction or fought for me. Whereas my biggest advocate was my mom. And when they told her, actually, there's no hope, she can't do it because she hasn't got time. When we realized we were kind of misled and just wanted to speed it up, that's why it hurt so much, because there was time. So that's why it's a bit like your choice didn't matter at that point.
I think, were you going to say something, Cheryl?
Yeah, I think one of the problems actually for lots of patients as well, lots of patients who I see, what they really want is to not feel they've missed a trick. And actually, sometimes we can't freeze eggs. Sometimes they decide not to, but I think they need to have the information. And I suppose, Becky, it's not completely helpful, but had you come to see me in 2008, we couldn't have frozen eggs because it was so unsuccessful. It's really only in, I'd say, in about 2010, 11 that we started freezing eggs with any chance of, at that time, it was really not very successful.
My thing though was, I heard of a story that in 2007 a bone cancer patient saved her eggs. I think she went private, but I would have even gone private if it meant that you wouldn't give it to me. And the fact was, you weren't given the choice to even go private because they made out like there wasn't enough time. I think really it was the techniques weren't very good. So I don't, some people it worked, but it was the chance of it working was very, very, very. But my thing is, I'd rather have the chance than no chance, because then when you have a leg amputation or breast reconstruction, you might as well say, it's all dependent on the opinion. And so if you're not going to let people go private or, tell them, well, if you can, but it's a low chance of it working, to not even give you that chance. Yeah. I think it was that I suppose what I'm just trying to say to you is, I think had you done that, it wouldn't have unfortunately resulted in a baby. And I know in 2008, when we were seeing patients, we only went ahead with treatment in patients who had a long established partner, and we froze embryos, because freezing embryos. And that's what I also think is kind of discriminatory as a single woman. I think that also plays against me, regardless of age, because why should it be only with the people with a partner? Because then you're kind of, I know what you mean, but it plays of the techniques. We couldn't freeze. It are very, very difficult. But that's what I mean. Then it plays people off each other, because that person can get it done, but that person can't. And even if the odds are low, it just seems unfair that, it's made kind of clear for one person to get easier access, but the next person is kind of not told enough, or which doesn't, helpful, because then it's each patient is going to feel like you're comparing, because you're thinking, why did that person get access, or why were they, that kind of thing. So I just wish it was more equal. Even if you said you've got no chance, or 10% or 1% of having a child, it was the fact that the choice was so important. And even if I never went on to have children, it was just taken away like that. Whereas the other patient in 2007, having her eggs frozen, it's kind of like saying one over the other. You choose one over the other.
I think, Becky, if you'd just been given the opportunity to talk to somebody like Dr. Fitzgerald, rather than just being told when you were too far down the line that no, there's not enough time, I think that would have.
I also think, as hard as it is, if they had said to me, there is time, but we don't really want you to go through this X, Y, Z, I would have had more kind of, not saying I disrespect them, but more respect that they made it, that they know that you've got a small chance of saving it, but they prefer to go ahead. Then that leaves it up to me. If I want to go private, I go private. If I don't, I go with them. But if you don't give people the chance, you might as well be taking different things away from them during the journey, if that makes sense.
I think it's all about giving somebody the ability to make an informed choice.
Yeah, and the patients that we see, I mean, I'd say possibly, I mean, I think over half go on to freeze, but a lot don't.
Yeah, and that's the thing where I think it's good you're giving them that choice of.
Yeah, and I think they don't want to look back and think they've missed a trick.
Yeah.
Missed that opportunity.
And like you said, I think if I'd spoken to someone like yourself, we could have spoken in depth, and even I could have changed my mind. But the fact is, I had no support, no mental health, no fertility support from specialists, and then you're just left to get on with it, and then not told. You know, you might go through the menopause, which I wasn't told. So we thought, you know, before my mum, we thought, oh, what's happening? Why am I always hot and, you know, sweating? And then we realised I've been suffering through the menopause, and there was no support for that either. And that's kind of why I started the campaign. It's as much about the fertility as it is the menopause as well, because there was no support for that. And that's not like fertility where you say, well, there's no chance of having a child. So to me, it felt like none of it was being looked at. And even young men and, you know, minority communities before today, like this kind of time, you weren't thought of as an individual or how it affected you, if that makes sense.
Well, that actually leads quite nicely into my next question, Becky. It was all about the campaign that you've started, Cancer and Fertility UK. Why, I think you've answered it a bit, but you could tell us a bit more about why you started the campaign and what you've achieved with it so far?
Part of the reason for starting it is, even though I lost the chance to have my fertility and I've gone through a permanent menopause, I wanted to use that pain for something positive. If I'm going to be thinking about it, I might as well be doing some sort of work around it. I thought even though I need to take small steps back to like self-care, but I thought it's good that if it's going to be on my mind, I'd rather help the next person, even if they don't go down that road. And even if the person said, you know, the chances of, like you said, like Dr. Fitzgerald said, the chances are low. If they know that, but if you tell them nothing, it's kind of like, oh, did I have a chance? Or, you know, and I know there's like 200 cancers. So when people kind of brush us all with the same, you know, like, oh, don't worry, you'll have a miracle child. Well, if I have no eggs and I'm like an older woman, I can't go back. So yes, X, Y, Z might, but we shouldn't say to everyone, you know, don't worry, you know, there's people out there that have had children, but someone in the world isn't going to have a child because of something like this. So that's where it kind of hurts, and it is quite a painful subject, and that's why part of me didn't want to bring it up, because I thought it might be too, you know, hurtful for a lot of people. But then I thought that's the whole reason why I probably should, because the reason when in 2008 society made you feel like you couldn't talk about it, and that XYZ is the most important. And when people said, you know, I'm not saying this is just for personally me, the fertility thing was worse than the cancer itself. And losing my dad, like, he died sadly from pancreatic cancer, but there's all support, and people kind of will say they will give you support because they know that's a really bad thing. But with fertility, it's not seen as, you know, a subject where people are, you know, have as much empathy as you're grieving a loss. And my thing was, your brain is a weird thing, and some people might be wired different, where the smallest thing for you, that means nothing, could be the biggest for them. And that's all I wanted to say, is rather than playing off patients about different things, to me each thing is important. So breast reconstruction, wigs, if it's your quality of life, you know, it's a very important thing for you. So I don't want to be mine's worse than yours kind of thing. I just want to be on the same line. And I just wanted to give patients that chance, because you feel guilty for talking about it because you're not dying. So why are you talking about something in the future? But really, that's how PTSD and things like that work, where you can't help it. You weren't that person. Like, before I was 21 and had bone cancer, yes, I was maternal, but it wasn't the end of the world. But then once you realize actually that's been taken away, it's weird, because when you're young, you know you might die, but you think it will never happen. But I never in my mind thought about fertility. And I think that's why it's good with education around fertility nowadays, that it's important, it's talked about, so the trauma might be less for the next generation.
Yeah, absolutely. I think it's like Louise and I were saying when we were chatting to you the other day, it's a very generous thing that you're doing, because you're using your experiences to try and make things better for other people, and you know, you're raising awareness about this area, which is incredibly important. So you know, it's fantastic what you're doing. You must be
I think the other people, I've seen some of the YouTube videos, and they'll probably get this, where you've got too many side effects and you feel like you're not doing enough, so you kind of put a downer on yourself. So my thing was, at least if I started this campaign and nothing big came out of it, my main thing was they're going to speak about it, because I knew with technology, the next blog or vlogger, cancer vlogger, wants to say, I've done this topic, tick. And charities don't want to feel like, well, we need to mention it with all charities, because it will make us look bad. So I knew society was slowly, so I did like reverse psychology. And I knew, and then that's how people got talking, and people wanted to share their stories, and like I'm doing a podcast at the moment, and even though it's hard because I don't want to delve into people's personal lives too much, it's nice when people do want to talk about it as well. It kind of will help someone else who relates to them.
Yeah, absolutely. And the last question I have for you is, if you know, what would your message be to a patient who's now approaching cancer treatment regarding their fertility? What would you say to them?
I'd say do lots of research. Maybe you look for a second opinion if you need it. Ring around fertility clinics maybe, and see if there's future fertility trusts that they fund the fertility treatment themselves, or someone like Dr Fitzgerald, and ask her opinion, and she might say, well, XYZ might be able to help you in Manchester. Or and I think also that if you feel it's not right, just go for a second opinion. Don't feel that it's going to upset the doctor, because you've got to live with that. And also, if your oncologist doesn't do the funding, you can technically go to your GP. It just has to be a medical professional. So if you want to bypass the oncologist or the thing, you've still got a GP that can refer you to the fertility clinic. So there is ways around it. It's just no one knows those ways until they talk to other people, and then by then it's too late.
It's all about dialogue at the beginning, isn't it?
Yeah, I'd also say it can be for some people traumatic, so you might not be in shock at the beginning, and later down the line you might want support. So if you feel like your thinking's going that way, to definitely ask for support. Maybe nowadays they might do specific on fertility support, but definitely ask for someone who knows about fertility, because when I had support for talking about it, when you talk to someone who doesn't know about young people, let alone fertility, you need someone who knows that world. So maybe ask to be sent that direction. And also your support line, like I didn't have that in 2008, so you could ask your BCRT and you could direct them maybe, or say and to realize, unfortunately, obviously, not everyone's going to get a happy ending, but obviously there will be hope. But like Dr Fitzgerald said, they can only give you the statistics of what might work, so it's never 100%, but it feels like an insurance until you have to deal with it later on.
Thank you.
Okay, that's lovely. Thanks ever so much for that, Becky. It's really good. So we've had a couple of questions whilst Becky's been talking. The first one is from Kirsty Hopgood. If Kirsty, would you like to ask your question to Dr Fitzgerald?
Yeah, sure. Hi, thank you both for coming on today. My question is just around, for those people that haven't had a chance to preserve fertility, what are the options available and what challenges come with these options, particularly around age? So whether you be like late 20s, early 30s?
So I think, so one of the things about fertility is funding. And certainly with the patients who are having banking before chemotherapy or radiotherapy, that the funding around that is now getting better. Certainly in Manchester, that's always funded, so that's funded in the NHS. That isn't the case everywhere, but it's getting better. Once you come back, once you have completed your oncology treatment, you then become a fertility patient. And it doesn't, in the eyes of the kind of NHS, the reason that you've become a fertility patient doesn't affect the funding. So you will face, unfortunately, the same funding restrictions that any fertility patient faces, which I certainly don't agree with, but that's the world I live in. As far as treatment's concerned, I think what you need to do is you need an assessment to look at your egg number. So I think, first of all, if somebody's having periods, if you're having periods, you are releasing an egg each month. Absolutely. You don't need blood tests, you are releasing an egg. If the sperm count's normal, you're releasing an egg. Then that's two of the things ticked, if you like. And then the third thing is, can the eggs and sperm get to each other? So is the pelvis okay? So it depends a little bit on the treatment you've had. So if you'd had you know, an osteosarcoma in your arm, and you had chemotherapy, and even if you had local radiotherapy, that radiotherapy wouldn't affect your fertility. The chemotherapy could reduce your egg number, but if you're having periods, you will be ovulating, so actually you may still get pregnant. If the chemotherapy has caused you to run out of eggs completely, then the only option then is going to be treatment with eggs from a donor. Now that isn't how anybody sets out to have their family, but certainly it's something that we do very, very commonly within the world of IVF, and it's extremely successful. It's pretty straightforward, and it's very successful. If you've had to have pelvic radiotherapy, then that becomes a very big problem, because then there's a relatively high chance that the womb may be affected and wouldn't be able to support a pregnancy. And in that situation, you'd have to look at egg donation and surrogacy. So it depends a lot on the individual situation, really, but they're all factors that need to be drawn together. But I would say to anybody that there are always options. They may not be the options that you set out with when you were much younger, but there are always options of some description.
Awesome, thank you. Just following on from that, you mentioned things like, you know, obviously funding and things it stays the same whether you've been a cancer patient or if you're just going through fertility treatment anyway. Are there age limitations on that?
On NHS fertility treatment, there are. So they vary between different areas. So as I say, we cover, our IVF unit covers Greater Manchester, so we cover up to Barrow and down into Cheshire, quite a wide area. So we actually have various guidelines within our unit because of the different CCGs. So the CCGs are the organisations that pay for healthcare, and depending on the CCGs, you know, different eligibility criteria apply. Most CCGs either have a cut-off of under 40 for the female partner, but some now have a cut-off of under 43. But that will depend a little bit on your age. They will bring in other things like weight, smoking, that sort of thing. And also, obviously, as you get older, even if you haven't had any chemotherapy, the egg number goes down. Unfortunately, women lose eggs as they get older. All women lose eggs as they get older. So often in a woman who's 40, even if she hasn't had treatment, there wouldn't be, the number of eggs isn't sufficient to undergo fertility treatment. But that can all be, you know, quite easy tests. You know, an ultrasound scanner and a blood test can give you a very good idea as to what those options would be.
That's wonderful. Thank you so much for answering my question.
Pleasure.
Did you want to say something, Becky? I saw you.
Just that, like what Kirsty said and Dr. Fitzgerald, that's something that I think patients should have for free on the NHS, because if you can have, you know, if it's not life threatening, but you can have breast reconstruction, you know, a leg, you know, prosthesis. To me, that because it's done by a medical problem, when they say you can have medications for free as long as it affects you, your cancer treatment affects you to this day, technically to me that should include that. And I'd love if, you know, with other people that is included as well as any other kind of quality of life thing. But I know it's very hard, because I just wanted to say before I forgot that the pandemic, we're going to, not just fertility, we're going to get people who, like me, are going to be missing out and sadly diagnosed late. And I think the pandemic is going to bring up a lot of new things, as well as with fertility, where it might not even be a chance, you know, with other things going on. And so I think we have to be aware that there's going to be a lot of people affected through that as well, sadly.
Yeah, I agree, Becky.
Just got another question for you, Dr. Fitzgerald. It's from Claire Pendlebury. She's saying, are there national guidelines, standards or pathways for fertility preservation for people with cancer?
NICE, which is the National Institute for Clinical Excellence, and they're the sort of, that's the body that recommends treatment that should be provided on the NHS. And NICE says that actually patients who are going to have treatment which will significantly impact on their fertility should be given access to see a fertility specialist and to discuss the option of egg storage or sperm banking. The problem with NICE is it doesn't actually have CCGs who pay for all healthcare do not have to follow NICE guidelines. So it's quite a big stick to CCGs, because if NICE endorse it, then you really should aim to provide it, but you actually don't have to.
That's the bit that,
which is,
when I find out it was only a guideline, that's what hurt me, is that, well, if I was not for it, I'm not going to care then, I'm just going to not do it. And I think that's why as patient bodies, we should, things like that, as well as other things, we shouldn't let them kind of be able to get away with it and swerve left.
So I think in the world of fertility, we have NICE guidelines for all fertility care. I would say now, certainly in Manchester, the guidelines for oncology patients, that is provided. Actually, the other NICE guidance for fertility is far from covered. So it's fertility as a whole is just not a high priority area. And you know, I've spent my whole life working in fertility in the NHS. I don't do any private medicine, only work in the NHS, and it's really difficult because frequently we can't treat patients that we want to because of funding. But as I say, NICE has endorsed it, and I think NICE endorsing it did help, because that does give an extra little push. And I do think it's getting better, but it's still got a long way to go.
Do you think we might go like America, where, like Future Fertility Trust, where charities might fund it rather than the NHS if it goes really bad?
I mean, charities can. I mean, I know there are individual charities that can fund fertility treatment, but I don't think that's...
I want it to go that way, but at the same time, it's scary to think that, you know, like you said, it's not a priority, and even I know that, but it's hard to hear, because you can fight, like you say, you're fighting for it, but people don't always think it's that big of a thing.
I certainly think for urgent fertility preservation, I think that has come a huge way in the last 10 years. Yeah. I think it's so much better. I mean, when we started, we had a lot of conversations with the predecessors of the CCGs about funding, and it was a really big thing to get them to agree to it. But certainly, and then, you know, we were a slight outlier, I think, in Manchester, but certainly over the last 10 years, it's improved dramatically, really, which is great.
Yeah, definitely.
We've just got another question from Vicky Lockie. Are you okay to ask the question, Vicky, to Dr. Fitzgerald?
Yeah, absolutely. So I'm based in Newcastle, and we started maybe last September doing cryopreservation. So oophorectomies for young girls, well, all girls actually. And we are doing it on prepubertal boys as well. I'm aware that, and this is through Oxford, and obviously massive and an amazing thing for, so now all our females, whatever age, I mean, we did a 23-month baby a few weeks ago. So that everyone's being offered it, and I don't know of anyone who's refused it at the moment. And I know that some other centres are doing this, but it's not nationally available. And I just wondered sort of what the situation was with that, because that makes it a bit of a postcode lottery, and whether it would become, if it's something that all centres are going to be able to offer in the future.
So certainly in Manchester we work with the group in Oxford, and we prepubertal girls do get ovarian tissue harvesting. I think for post-pubertal girls, it's quite, the problem isn't taking an ovary out. If somebody's, there's that thing is a cycle of egg freezing going to give you a better chance than an oophorectomy? You know, maybe you could do both if you've got time to do both. I think the problem is when you take an ovary out, that operation reduces your chance of getting pregnant in the future, because that takes half your eggs. So I think the kind of selection for the patients who you would put into having an oophorectomy is very, very important, because you would only put into that patients whose treatment is really, really going to affect their fertility. So a lot of patients we see, so girls say with Hodgkin's lymphoma, their first line chemo tends to be not very damaging. So you certainly wouldn't want to take their ovary out, because that would cause more harm than the chemo. But we do give them a cycle of egg freezing, because that doesn't reduce their fertility. So I think you have to look at it very much on a case by case. I think certainly the group that's very good for is prepubertal girls, because you can't freeze eggs in those girls. So certainly I think freezing ovarian tissue at that stage, it's still, so ovarian tissue cryopreservation in post-pubertal patients has been, you know, proven, and they've had babies. They haven't actually had babies from girls who were completely prepubertal yet. But I don't think there's any reason to think that couldn't happen. But it is quite an invasive procedure, so I think the patient selection is really important. Similarly with testicular tissue for boys, that's still very much in a research setting, and I think should be. I know they're doing a lot of work on that in Edinburgh as well, and I think it's certainly something that, because what you need to be, these things need to be done properly, and they need to be done when we know that they're effective, or within a research setting really. But when we were talking about things getting better in the future, you know, I think there are developments, and certainly the other problem with ovarian tissue freezing is that to use that tissue, you have to put it back into the woman. So you have to be very sure that there's no oncology tissue in the ovarian tissue that you freeze, because otherwise you give them the cancer back. So, you know, there are lots and lots. It's not a simple fix all. You know, it's certainly one of the strands in this whole thing.
Yeah, and I think we're the same. We don't offer it for our Hodgkin's, because our first line of treatment is low fertility risk, but it's more for our solid tumour patients. Again, it has to be assessed and what have you, but it just, to me, it feels, I think, sort of listening to what Becky said many years ago, you know, I was sitting at I'm a TYA nurse specialist, and we're sitting at a Find Your Sense of Tumour conference, and a couple of our girls said that they hadn't realised that their fertility was going to be affected, because nobody had talked about it with them, and we didn't really appreciate the depth of the problem, and the fact that if there were, even at the time, there wasn't really anything available for them. Sort of, as Becky was saying, it was the fact that nobody had even addressed it with them.
Yeah, absolutely.
Had that conversation, and I think now that we have although it's not applicable for all, but it's definitely something that we could offer for some of our girls who don't have partners and do need to start treatment straight away, because when we're putting a line in, we're doing it sort of at the same time. So it just,
I mean, I think there are rarely cases when you don't have time to egg freeze, to be honest. I think, you know, because nobody goes to their GP and starts their chemo within a fortnight. I think it's about raising that awareness really, really early on.
With you saying that, just a quick thing, I feel like maybe sometimes people say that because if it hurts them to know they couldn't get their fertility saved by saying when the doctor says there wasn't enough time when there might have been. I don't know if it's like to stop them feeling pain. So a lot of people say, but there wasn't enough, but we don't know if there was enough time.
I mean,
If the doctor
I think there are some situations, so girls with leukemia with an acute leukemia don't have enough time. Unfortunately, you can't freeze their ovarian tissue though, because that's too dangerous to put that back in. But I think with most other patients, I think ovarian tissue freezing, absolutely, for those pre-pubertal girls, because there's nothing else you can offer them. I think anybody who's post-pubertal, so certainly, you know, we've frozen eggs on girls who are 14, 15. And actually, if you're post-pubertal, if you get referred in, as long as you get referred in early in the pathway, there is time, and you can fit this in around oncology visits and oncology scans and all that sort of thing. I think it's that thing of it, you know, I mean, you know, we're preaching to the converted because we're all saying the same thing here, is that actually it's about raising awareness and it being raised really early in the pathway to give people time to do it.
Can I just quickly ask, ovarian tissue, if you tick, you're good for it, for what would each patient, is age against them, or is it a type of cancer, or like, because there must be only so much funding with ovarian tissue. Is that any different? Or
it's not really about funding, it's about the fact you wouldn't want to do it on somebody where there potentially could be cancer cells in the tissue.
Okay, yeah, that's different. Yeah, so it's not judged against you for anything.
It's a procedure that does significantly reduce your fertility, or can significantly reduce your fertility. So you only want to do it in a very high risk situation, really, because you wouldn't want.
So would you recommend, so like you said, when you do the pelvic area, like myself, if it's probably, you know, nearly 99% probably going to be destroyed because it's all to that area, is that the kind of chance when you think they probably won't have their fertility? So even if it's a low odds, it's worth the chance, if that's
so. Yeah, I think if you're having somebody who's going to have really very high risk treatment, and you know you can't freeze eggs, then that's the sort of, and certainly the pre-pubertal girls, because you can't freeze their eggs. So if you had a pre-pubertal girl that was going to have pelvic radiotherapy, you may well freeze ovarian tissue. Or if she was going to have very high dose chemotherapy, you would freeze ovarian tissue. The problem is with pelvic radiotherapy is that it also affects the uterus. So you would be able to use those eggs, but you would need to use them with surrogacy. And that's another all of that level of difficulty. Again, possible, absolutely possible.
But you give people even though, like you said, it might not be, like I might not go on to adopt because I physically can't do it at the moment, but that's not to say that if I had good health that I would, maybe. And also, I think we also need to maybe that maybe you don't, because everyone's different, maybe you end up not having a child, but you might have to kind of get used to that and build your happiness up again, if that makes sense. So making like all options that, you know, it's okay if that's for you. You don't have to, you know, there isn't every way you have to go. So, because I always get, well, you can adopt, but what if I didn't want to adopt? You know, it's just kind of thrown onto you. So I think if we give more like, you're the person, you decide it's your life, you know, no one else is going to live it, then it shouldn't really matter what you end up doing. And I think that might help with your mental health, because then you won't have people giving you one option all the time, if that makes sense.
Absolutely. Were there any more questions at this stage? We're kind of coming up to 2 o'clock now.
Sorry, do you mind if I
Yeah,
put in
of course. Yeah.
All right, thank you. It's just really around, obviously, you mentioned about the thing about not having time, and it's very rare that people don't have time. And actually, from personal experience, I would say it's just more maybe the team you're working with, like you say, they're more worried about saving your life.
Yeah.
So with that, where do you think, how do you think that could improve? So like, what do you think needs to be done to ensure that people, that you're maybe in your first ever appointment, that's brought up as a topic?
Yeah. I think it is all about education. As I said, I think the difficulty with that is there's not an easy fix for that. I think it's something that's you know, I suppose there's always a bit of a time lag with things. You know, so 15 years ago, 12 years ago, we couldn't really freeze eggs, so it wasn't really something that people would think of doing because there wasn't anything you could do about it. I think once you can start doing it, it then takes time to get that out of my world of reproductive medicine into the oncologist's world, because I think that's the absolutely crucial. I think, you know, things like, you know, Becky's charity.
I'm not a charity, by the way. Just
sorry, not a charity, the Becky's organisation. You know, the bone cancer charity, I think they're all really important. You know, patients, it's all about just getting that message out, really, that, you know, patients to bring it up. And I think, you know, I know we've worked very closely with the oncologists, but over many years, because it takes a long time for it to almost get embedded in, actually, when you start off, oh, somebody's got, you know, some kind of mass they shouldn't have. Oh my goodness, is this malignant? Right, what might happen? Oh, we better get to see the fertility person. That almost that mentality. And I think, you know, we do see patients often. You know, I have patients referred in now that don't need to see me, but that's great. You know, that's better. But I think it is a long thing to get this information out there. But I think it's really important for patients to know, if they, you know, if they're seeing an oncologist about anything, just bring it up. Say, look, can I speak to somebody about fertility? Because they will facilitate that. You know, and actually, certainly seeing somebody, that's always funded in the NHS. You know, any funding issue may be around whether you can go on to egg freeze, and I think that's getting better. But certainly, seeing somebody, you can always see somebody. So I think it's just that awareness, and I wish I knew a quick fix on how to do that, really.
It's almost like when, say, a GP refers a patient to one of the bone cancer centres because he suspects that there's a sarcoma. At the same time, they refer the patient, if applicable, to a fertility expert. So he's sort of starting it right at the very beginning.
Yeah, that's my thing.
Yeah. And then there is time, because there's, you know, I mean, we see patients within a couple of days and we get them started straight away. So I would say to somebody, we kind of need the best part of 3 weeks. Really? You're very rarely from.
Did you do it when they send some of us? We have our biopsies sent away, and it takes a little bit of time. Could you not even start then? You know, like
that's exactly
once you know you have roughly cancer,
That's exactly what we do. Is that we see patients before sometimes the diagnosis is confirmed. So we've got everything in place.
Yeah, that makes more sense.
And then, you know, literally as soon as that's, you know, then they just start. Yeah.
And it's, as you say, sometimes you may have to turn patients away because they haven't got a malignancy, but if they're in the system.
Absolutely.
And if someone has questions, sorry.
So that's nice, that's great. You know, if we say, oh, we saw you, but we don't need you.
And if someone has questions about fertility post-treatment, so they're saying 6-12 monthly review appointments, is it easy for them to be referred by the GP or to talk to them after their treatment? Is that
so I think I'm sure that is different in different areas, but I think patients can always say to their GP, I want to see a fertility specialist.
Okay.
Absolutely. And I think, you know, because, as I say, there are so many things that impact on it, you do need to see somebody. You can't just think, oh, I have this, therefore I need that. You do need to see somebody, but absolutely speak to your GP and say, I'm a bit worried about this, because, you know, there are, you know, certainly, you know, patients who've had breast cancer, there are big issues in them getting pregnant afterwards. You know, they may have to interrupt their treatment, and you have to kind of almost manage getting pregnant in a much more kind of, can't just say, oh, just go and have a go. You have to really manage trying to get pregnant. And the one thing I would say to anybody who's had chemotherapy, even if their periods come back, their window of opportunity in which to have a pregnancy is going to be reduced. So even the girls who have Hodgkin's, I would say to them, you've had chemo, your egg number will be reduced a bit. So in the future, have your babies early. Well, I'd say to everybody, have your babies early, because...
Will they be judged, though, if they have a partner that has a child from another marriage? Are they judged like that, where they won't be given the fertility treatment because if you're judged by your BMI.
Most people who have chemo don't need fertility treatment afterwards. Most of them just.
I mean, if they did, would they be judged if they had?
That's like all fertility patients.
Yeah. Because I think, like freezing the tissue, I wish that not everyone had to pay for that either, because that should be like an emergency thing. And then down the road, if we're going to fight for fertility treatment, but the freezing, in my opinion, you shouldn't have to pay for, if that makes sense.
Oh no, so that's certainly in Manchester, we can freeze if we feel clinically we need to freeze. There are no eligibility criteria. That's not the case around the country, but it is.
Yeah, I think it's 300, is it a year, or for some people, I think they said after so many years, but I think that's something we can fight for, to try and, like you said, but I think maybe if we worked with doctors like yourself more and raised the issue, I think it'd be less of a kind of no one knows what's going on kind of thing.
Okay, we'll close it there, but I think all is left to say is a huge thank you to you both, to Dr Fitzgerald and Becky, for coming on to speak today about such an important issue which perhaps hasn't always been